We'll go ahead and get started. We want to be mindful of everybody's time. We appreciate everybody hopping on. Again, if you can put your information in the chat for introductions, your name, your email, your organization, your credentials, we'll save that. Also, just again, for those who just popped on, if you're able to put your video on, we would really appreciate that. It helps with engagement, knowing who's there. We will not pick on you just because your video is on. So that we just want it on. So if you can do that, that'd be great. With that being said, I'll turn it over to Laura. Laura, did you want to share your own slides or did you need me to pull it up?
Yeah, I'll share my own slides.
Okay, you should be able to do that.
Okey-doke. All right, see that?
Yep.
Okay.
Good to go.
Good afternoon, everyone. I'm Laura Lander. I'm social work faculty in the Department of Behavioral Medicine and Psychiatry. This is pregnant and postpartum women's substance use disorders. ECHO, good to see everybody. We're going to talk about addressing stigma experienced by individuals with substance use disorder who are also pregnant or postpartum. So we know anyone who works with this population, we see this a lot in lots of different settings. So we're going to talk about kind of what we see, some of the issues that are most likely to come up and how to address them. So overview is we'll define stigma a little bit in its origins, causes, contexts, who's responsible, a little bit about the research. This is not a research heavy talk. But also the most concerning thing about stigma is really how it affects access to care for patients and retention in treatment, and then what we can do to help reduce it. I am totally fine with people putting questions in the chat or asking questions and interrupting me. I'm happy to have this be more discussion based, and as we kind of talk about these things, if you guys think of examples of when you've worked with people who have experienced stigma, we can talk about that after the didactic piece as kind of an impromptu case discussion. So what is stigma? So the general definition is it's an attitude, behavior, or condition that is socially discrediting. So seeing someone as less than in whatever social context they might be in. And it can happen at lots of different levels. So public being community, institutional, healthcare settings can be stigmatizing. It's funny, I was coming in our building, and I don't usually come in the front door. And coming in the front door, the big signs are, you're going to go through a metal detector. And then the next sign I saw was, no family visitors. I was like, oh, this is not very welcoming to our patients, and that can feel stigmatizing to patients, that it's not like, please come in, we're here to serve you, or we're here to help you, or we're here to provide support. It's a whole bunch of like rules about what you cannot do. So I got to talk to somebody about that. But so it can really even be in our hospital signage is one example. Private stigma, so that can be within people's families. We certainly know that many of the women that we work with experience stigma in their families around having a substance use disorder. And then there's personal stigma. So we frequently have discussions with patients who are on medication for opioid use disorder, and they stigmatize themselves, like, I'm not really sober because I am on this medicine. And so there can be self-stigma. There is a lot of research on stigma. There's not a lot of research on stigma specific to the PPW population, but we certainly at the clinical level see that. Research shows in general that addiction is the most stigmatized condition worldwide, more so than other mental health disorders like depression or schizophrenia even, and more so than other chronic diseases like diabetes or heart disease. And even among healthcare providers. In fact, healthcare providers can be some of the worst perpetuators of stigma, sometimes knowingly and sometimes not knowingly. So educating people is really going to be a big part of combating this. and that pregnant individuals with substance use disorders are the most stigmatized among individuals with substance use disorders, even by their own peers with substance use disorders. So if you are pregnant and struggling with substance use, you're really bad compared to if you're not pregnant and struggling with substance use. So it's kind of this loop and you can enter the loop at any point and create stigma by labeling, stereotyping, thinking of like that's them, they're different than me, us versus them mentality, discrimination, and then loss of social status is one of the consequences of stigma, and they all kind of build on one another. And some factors that influence stigma are beliefs about what causes whatever it is. So in this case, the substance use disorder, and whether or not the person can control it. And so these are kind of some quotes related to that. So if you believe causally it's not people's fault that addiction is a disease and you don't choose to have a substance use disorder, that decreases stigma. If you believe it's someone's fault and addiction is a choice, then that increases stigma. And then what they're supposed to do about it, they can't just stop. They can't, stop without help. That decreases stigma versus, the Just Say No campaign did not work because addiction is actually a disease process in people's brains. And but if you believe that if you really wanted to, you could stop, and that therefore, because you're not being successful in discontinuing use, it's some kind of lack of willpower. So I always, whenever people say, "Oh, willpower," I don't have enough willpower, I have lots of willpower, I often will talk a little bit about willpower. And one of my former colleagues, Dr. Sullivan, who you guys, some of you know, what he used to say about willpower. This is gross, but he used to say, it doesn't matter how much willpower you have, because if you have to go to the bathroom and you're having intestinal distress, you can have a lot of willpower and you still cannot stop yourself from going to the bathroom. So he would get really descriptive and gross, but it would make a point about it's a biological function. And so we cannot always control our biological functions, especially in a disease state. So some of the origins of stigma, and there are many origins of stigma, but one of the best studied ones is really the criminalization of addiction. And we have criminalized addiction for over 100 years. And so we still criminalize addiction. There's a long, long history of this, starting with the Harrison Act, where literally it became illegal for physicians to treat opioid use disorder with medications. Specifically, the way that we treat it with methadone or buprenorphine, that was illegal for a long period of time. And so doctors were then arrested and had criminal charges against them for treating individuals with opioid use disorder. So long history of criminalizing medication for opioid use disorder, as well as individuals who use substances. Prohibition, everybody knows about prohibition, that obviously criminalized use in general, and it was repealed in 1933. But it really persisted in this widely held belief that substance use disorders are a moral failing, and that's where that was seeded. It's interesting, there's some debate today around, you guys know, CRF Part 42, separating out the medical record of individuals with substance use disorders from the rest of their medical record, and it's meant to be protective. Some people argue that it actually perpetuates stigma and is not a good thing at this point. So that's really under debate. But typically, substance use disorder treatment is kept separate from the medical record. So moving into the individuals we work with, so pregnant women with substance use disorders, this is just a little bit of a breakdown of most commonly used substances. So this is from SAMHSA from 2020. And so tobacco and alcohol remain the most commonly used substances among pregnant women. And then you see marijuana is a third in there. So just to kind of put substance use among pregnant and postpartum women in context. So where do we see stigma show up? Healthcare settings, in the OB, in the emergency department, primary care, and in substance use disorder treatment. I remember when we first began to have a large medication for opioid use disorder clinic here in this building where I work, which is Chestnut Ridge Center, where there are we treat individuals with mental health disabilities and disorders and problems. And they did not want our people in the waiting room. Which I was like, really? That sounds really stigmatizing to me. I mean, literally, it was our patients being stigmatized by mental health providers in our same building. It was remarkable. So it can happen in lots of different settings, even settings in which the treatment of mental health disorders is the focus. In families and local communities, we certainly see that in local communities where people are blamed for their substance use disorder and really marginalized among recovering peers. So we used to see, and we still see a little bit, but less so, individuals on medication for opioid use disorder are stigmatized by their recovering peers who are not on medication for substance use. And so there can be stigma among people's peers, and specifically around medication-assisted treatment. Providers are also stigmatized, so providers who provide treatment for individuals with substance use disorders and providers who prescribe medications for opioid use disorder and other disorders. So we also experience that. And who spreads stigma? So everyone can really do this. Again, sometimes it's knowingly, and sometimes people just don't quite know the right language to use and are not aware of the way that they're talking about a client is stigmatizing, or even the way that they're thinking about a population is stigmatizing. So we need to remind people as we move through the world that this is a chronic primary progressive neurological disease of the brain. This is kind of a mishmash of the NIDA and the SAMHSA definition of substance use disorders. And these are the 5 main areas impacted. So impaired control over use, compulsive use, continued use despite harm, craving, tolerance, and withdrawal. And sometimes when you share this definition with people, they will be able to use a different lens to view some of the behaviors that they're seeing as bad behavior, or as just not getting with the program, or not wanting to be well. So there is some research on stigma for pregnant and postpartum women. A lot of it is qualitative interviews, which are definitely really interesting. And Racine is one of the people who's done some research and did a study where he found that pregnant individuals are more likely to be viewed as having a biological and moral basis for their addiction compared to non-pregnant peers. And then there is this scoping review that looked at all of this, many studies done by Bright in 2022. And some of the primary findings are that stigma in the pregnant and postpartum women population occurs at all levels, so healthcare, community, and self, like other individuals. Comprehensive care is necessary, so that combination of OB and SUD for the best outcomes for mom and baby. And that stigma as a barrier improves with strong social supports and access to that comprehensive care. So again, models that integrate, if possible, substance use disorder treatment and OB care are really ideal. What PPW specific stigma can look like. So often patients are blamed for their substance use disorder, and it's worse because you're pregnant, why can't you quit? As if being pregnant somehow negates having a substance use disorder. It does not stop the disease process. And so there's an extra layer of blame because people feel like you are not only hurting yourself, but you're hurting your unborn child. People are called stigmatizing names. They often receive subpar treatment, and we will see this often in the obstetric setting if they're not treated adequately for their pain, or their symptoms are minimized. So this is true for all individuals with substance use disorders, say, who show up at the ED and talk about pain or disorders. They tend to have their medical symptoms minimized, like they don't know what they're experiencing, or are perceived as drug seeking. Also, many pregnant women are told they should not be on medication for opioid use disorder, whether that be by medical providers, their family, their partner, or they themselves are questioning that. And they're sometimes also told that they cannot breastfeed. So another study that was done by Burgess, and this was, he interviewed women who had experienced stigma in the hospital setting, and basically 50% of women said that they had. Women pregnant and postpartum women. So just a reminder of the breastfeeding recommendations from the World Health Organization and ACOG. Breastfeeding is encouraged, including for mothers on medication for opioid use disorder, and because it's good for everybody. So the impact of stigma, it becomes a barrier to people acknowledging they have a problem. So people keep it a secret because they're fearful that if people find out, they will somehow be punished or treated differently and treated badly. Stigma towards individuals with substance use disorders reinforces the misperceptions that people could quit if they really want to, and that they have chosen to have a substance use disorder. I think most importantly, people won't seek treatment. And so women, in a lot of the research that's done in the interviews over and over and over again, this is very clear that people see it as a reason not to seek treatment because their other children will be removed, so fear of CPS, or they will be mistreated in some way. And then individuals with substance use disorders are likely to drop out of treatment because of stigma if they're being stigmatized in kind of that healthcare setting, or even in peripheral healthcare settings. So it impacts retention in treatment in a negative way. The stigma towards healthcare providers decreases our workforce in terms of people wanting to go into the field or remaining in the field if they feel stigmatized by their professional colleagues. So in terms of treatment, access is already limited for pregnant and postpartum women. So to add another layer of limitation is really problematic. Another reason why it's so important to combat stigma and coordinating with obstetrical care. One of the things we did early on, so we created at Chestnut Ridge, we created a specific pregnancy clinic in 2011, and really knew right away that we needed to reach out to our OB peers in the hospital. And so we began to just have a monthly meeting where we would talk about substance use disorders and pregnant women and all related things, including neonatal abstinence syndrome and the treatment of neonatal abstinence syndrome. And I learned so much over the years about those about obstetrical issues that I didn't know anything about, and about the treatment of neonatal abstinence syndrome, because we had a pharmacist in that group and nurses. We had lactation consultants, we had neonatologists. So it was a great way to decrease stigma and also begin to learn about one another's roles with the same patient population that we all worked with. Participation in substance use disorder treatment increases OB adherence. So there's a fair amount of data on that, that they, if a person is coming to their treatment, they're more likely to show up for their OB appointment. And that treatment in all pregnancy treatment groups can really reduce stigma and shame and increase social support. So we see that in our all pregnancy clinic. So some specific post-delivery challenges when it comes to stigma is how patients perceive and are treated by the nurses and physicians and people who work with them. I think I'll put a plug in for doulas and midwives. So doulas and midwives typically do not kind of stigmatize patients. They understand the whole person, and they have training in addiction treatment. They understand addiction as a disease. But other nurses can either have their own personal biases around substance use disorder, or not have the experience that I get to have, which is people getting well from substance use disorders. And so really trying to support nurses in the hospital setting so that they are aware of how they might be transmitting stigma, and to decrease it is important. Stigma associated with NAS, so mom already feels terribly guilty if her baby has neonatal abstinence syndrome, and sometimes they can have additional stigma if the baby is not doing well from healthcare providers. CPS involvement, CPS can be stigmatizing, we know, and often patients feel punished because CPS is required to be involved if they're on medication for opioid use disorder or test positive for other substances. And then postpartum depression and anxiety certainly are challenges, stigmatizing family interactions. And most of all, patients, if they did use during their pregnancy, or even if they were on medication that was prescribed to them for opioid use disorder, they can have a lot of guilt and shame. If there's anything at all, wrong with the baby, they blame themselves. So any thoughts or questions before we talk a little bit about what to do? I don't know if there were any questions in the chat. Doesn't look like it.
Yeah, no questions yet in the chat.
Okay. So language is really important. As many of you guys know, many of us have changed our language over the years. So in the early 90s, when I started working with individuals with substance use disorders, clean and dirty was just how we referred to if someone had used or not, and drug screen results and all of that. So it took me about a year to stop saying clean and dirty when I talked about drug screens. So it can take a while to get out of these habits. And it's not about being politically correct. It's really about treating people with compassion and respect and talking about them in a way that reflects that. So these are some of the different suggestions on how to alter our language. And this other piece about compassion and consequences. So the reason people change is there are consequences to staying the same, typically negative consequences. So consequences are good. They motivate people to change. And so it is very important to have consequences, which is different than punishment. And so this combination of treating people with compassion and saying, if this happens, or if you engage in this behavior, or this is the result, this is what the consequence is going to be. Sometimes we as providers actually dole out those consequences. So if someone is in a residential setting and they are using substances in that residential setting and they're pregnant, they will be dismissed, hopefully with some kind of alternative treatment resources, but they will be dismissed because the milieu needs to be kept substance-free and safe. So sometimes we are doling out those consequences, and sometimes the consequences are natural consequences. So we have, we working with a pregnant individual who continues to use during the course of their pregnancy. We can retain them in treatment, and I will need to say to them, do you understand that CPS is likely to remove this child from your custody? So let's make a plan. Do you know who you might want the child to go to? I don't have to be stigmatizing about it, but sharing with her the reality that is likely to happen is also important. And maybe that will be a motivator, and maybe it won't. But it's sort of dealing realistically with the consequences of, say, continued use during pregnancy. And then as healthcare providers, there are certainly different areas that we can influence stigma. With patients, trying to reduce their shame and guilt is really, really important. Again, compassion can go a long way, although oftentimes they're they are going home to their families and receiving a lot of negativity. And so it can be hard to maintain that for them. And so if they come into treatment with us, at least we can create a space in which we accept them wherever they are. And we do not blame them for their substance use disorder. Offering support and validation, respecting confidentiality. So many times patients, if they're on medication for opioid use disorder or don't necessarily feel safe around family members, but family members come into the delivery space, it's really important to respect confidentiality in that delivery space, and as providers to know what they are feeling about, family members who may be visiting. Adopting a non-judgmental stance and treating patients with compassion like any other patient with a chronic illness. And advocating for patients who voice discrimination. So sometimes they can't, because of the power differential, they can't sort of call it out directly, but if they let us know, we can advocate for them with providers or whoever may be more stigmatizing, including family members. Any other ways that you guys as care providers help to reduce stigma with directly with patients?
I think, Laura, one of the ways is really in our language and how we refer to them, and so even if they're using language that's more judgmental about themselves, and it's not necessarily always confronting them about it, but just kind of in how we talk to people, it makes a huge difference. And, talking to them by their name, the group, what it's for, it's not, and so I think the language is real important that we use with our patients.
Absolutely. Yeah. Thank you, David.
I think sometimes, I've talked to patients about, their stance and their thoughts on stigma and how they present themselves to others and how important that is and what they want to do and how they want to present themselves to others, and giving them opportunities to actually present themselves to people, I think has been helpful too.
Yeah, and Kelly and I have a case we can present if we get to that. Because, and I frame it as empowering, right? That you may not be able to change stigma globally around, pregnant and postpartum women who are stigmatized, but how you act, including the way that you talk about yourself, is going to influence that stigma, as well as kind of how you present yourself in the world. So oftentimes helping people with assertiveness and how to be verbally assertive without blaming, accusing, yelling, cursing, all of those things, which are actually, if they engage in the blaming, accusing, yelling, cursing, it actually reinforces the stigma that people may have about individuals with substance use disorders. And so teaching them exactly, as you said, to present in a way that may surprise people while, sticking to your guns and advocating for yourself. So the other piece I think is really important is with coworkers. And this is not unlike racism. So whether it's, overt racism or kind of more subtle racism, that we have a responsibility to call it out when we see it. And we can do that diplomatically, raise people's awareness. But that is a really big piece of combating stigma, is with our healthcare colleagues and family members. So if it comes to that, so my family, my personal family is not always well versed on non-stigmatizing language when we talk about substance use disorders and what I do. So I can help to teach them at kind of a personal level as well. So sharing stories of success is hugely important. Many of our colleagues in healthcare settings do not see people get well. So we try, especially with our ED colleagues, to share stories of success all the time, and also to let them know. So I help to run a program in the ED where we have peers in the ED, and they work with individuals presenting who have substance use disorders, and letting letting the nurses know when they have done a really good job with an individual with a substance use disorder who comes into the ED. So giving that positive feedback, and also we can let them know, and they made it to treatment, right? Like what you did made a difference, and that can be helpful. And obviously using non-stigmatizing language, and then being aware of our own biases. So many of us have experienced substance use among family members, close family members, and we may have been really burdened by those experiences, or we may have had a very positive experience and that person got in recovery. So we have different biases based on our personal experience, and any transference that may come up for ourselves. So whenever I am working with 20-something-year-old people, I have 2 kids that are 20-something-year-old, like I have to be aware that they may, in some ways, consciously or unconsciously, remind me of my kids. And so my tendency would probably be to be overprotective, and that may, or enabling, and that may really not be helpful in the therapeutic setting. Any other ways that people have with colleagues or either within yourself in terms of influencing stigma?
I think really the biggest thing is like making, like when people make like very small side comments, to like call, not like we more so want to call in versus call out, but kind of like welcoming them in to have a conversation versus like letting it just kind of float and ride. Otherwise you're just normalizing that behavior and reinforcing those stereotypes. So if I'll have someone that comes in and is like, well, she's on Suboxone supposedly, but she's positive for everything else, like I'll usually just try to go, well, Suboxone only helps with people with opioid use disorder. All of the other things are abstinence-based programs. And so we don't have a medication for that. So it doesn't surprise me if she'd be positive for something else. So like not in like a mean way, but just to like kind of like reinforce that is probably the quickest, easiest example I can give. But that's what I have been trying to be better at doing when I encounter that.
Absolutely. That's a great example of kind of how to do that in a way that's not super confrontational or going to put people on the defensive. Thanks, Kelly. So just we talked a little bit about this. So there's treatment-related stigma. These are the treatment options for individuals during pregnancy. Detoxification is not recommended. And there's a lot of stigma around medications for opioid use disorder still. I am continually surprised. I should not be surprised, but continually surprised when I encounter this. Methadone also is more stigmatized than buprenorphine. So just the stigma related to opioid use disorder, this is a little bit older, but this is in a national survey. People generally view individuals with opioid use disorder as being to blame for their substance use. They characterize people as lacking discipline. They wouldn't want them to marry into their family. And they endorse discriminatory measures to address the stigma, such as not having them be employed in their settings or housed near them. And so individuals who had personal experience with opioid disorder, interestingly, were not likely to have a less stigmatizing view. So they actually had a more stigmatizing view, which is, again, just that reminder to check our own biases and be aware of our own biases, because just because you have personal experience may not make you less biased. And then this is the question that we often get with this population. And the answer is because detoxification doesn't work. And oftentimes the only way to engage someone is in treatment for opioid use disorder is to really welcome them in with the offer of medication as part of a comprehensive program. And it's evidence-based, and it saves lives. And just to review the benefits of medication for opioid use disorder. And I will talk with people about this and acknowledge the risks, right? So neonatal abstinence is absolutely a risk, and we're getting better at treating that and diagnosing it. Abuse and diversion is a legitimate concern. And most of the time when people are abusing or diverting medication, they're doing so to be well, to prevent withdrawal, because they missed their appointment, or because they can't get into treatment, or they don't have transportation, or they don't have adequate health insurance. And so to not to discount that there aren't risks, there are always risks when you prescribe a medication, especially in pregnancy, but the benefits typically outweigh those risks. And just I'll end with this was a study looking at the significant impact that being in treatment has on neonatal outcomes. So positive impact on kind of your basic neonatal outcomes of preterm birth, low birth weight, fetal death, neonatal mortality, and postnatal mortality. All these numbers get better when women are in treatment for substance use disorder. And just a summary, in general, language matters, how we talk to patients and colleagues. Factors that impacted our beliefs are our beliefs about control and controllability and causality in terms of substances. And then how do we combat it? Really educating both patients and colleagues, and having conversations, inviting people in. I like that, Kelly, versus calling people out, and treating people with compassion and respect. And instilling hope whenever we can. So that is that. So does anyone have any kind of off the cuff examples of how any of the patients you've worked with or the clients you've worked with have experienced stigma, and how you've helped with that? Or
Laura, we actually had a question in the chat from Wanda about why methadone is more stigmatized than Suboxone. Could you provide some insight on that?
Yeah, so it's a full opioid agonist, whereas buprenorphine is a partial agonist, and naltrexone or Vivitrol are an antagonist. So that has a little bit to do with it, but I would argue that actually our treatment delivery method has highly stigmatized a medication that is very, very effective. So you have to go to a methadone clinic, and you have to do daily dosing, and often methadone clinics are in not great sections of town, especially in urban centers. They're usually in bad, like, sections of the town that most people don't want to go to. And so buprenorphine has blown that model apart so that people can go to their local physician if their physician is able to administer buprenorphine. And so the way that methadone is distributed and prescribed is very, very stigmatizing. There is a huge movement in this country to change that. So NIDA is actually funding a fair amount of study around doing office-based methadone. So hopefully we'll have some good results from that, and we'll be able to change the way that it's prescribed and reduce that stigma. But if anyone else has any thoughts about why it's more stigmatized, I welcome that.
I think too, where the people who receive methadone, especially like right after their dose, they can appear like they're high sometimes. And I think that can, add to that stigma as well, even though I'm not saying that they are. I'm just saying, they get very sleepy. Oftentimes it's in the morning, so they've woken up early. And I just, I feel like I said, they have that appearance, whereas with Suboxone, they typically don't. Do you agree with that?
Yeah, so historically, and this is from patients talk about getting more medication that maybe they needed to be well. So sometimes methadone has historically been overprescribed. And so, I mean, people on an appropriate dose of methadone should not look sleepy,
Right.
but sometimes they may be on a dose that's a little bit higher than necessary.
And I will say, like, I feel like in people that I see in the clinic, and from my experience, when I talk to people, that in pregnancy, they tend to get overprescribed medication because sometimes there's a misconception with providers being so fearful of them going through withdrawal that they misinterpret that as that means that I need to put them on the max dose versus appropriately titrating it. I've also, from a provider side in the clinic, have like seen with my own patients and heard where someone will go get their dose in the morning and then come directly to their OB visit. And when the medication is at their like peak onset of action, that the maternal heart rate is lower and the fetal heart rate is lower, or maybe they came in and got an NST and the baby is a little bit flatter on the monitor, and then people kind of misinterpret those outcomes. So I think that can contribute a little bit too. I've also just anecdotally heard people say like, oh, they need to go to the clinic every morning, like they can't be trusted to have their own medicine. And so that kind of contributes to a stigmatized profile with methadone too. Like they're not trustworthy enough to like have the medication like in their home, and that they have to go and get watched.
And I agree with that. A lot of it's our delivery system. I mean, you can even imagine a line of people waiting for their methadone in some places and put a pregnant woman in that line. The other part, as Kelly was saying, in pregnancy, oftentimes patients will need split dosing because the metabolism is totally different. And so somebody who's not experienced could be interpreting that as trying to get more medication. We actually had one of our pregnant patients on methadone, and we did her urine screens, and she was indirectly observed. So either the center was selling her methadone, which is not likely, or she was being watched taking it. Her drug screen was negative for methadone because she was metabolizing it so quickly. We split her dose, and then it was positive. But try to explain that to a court. They're like, oh, where is that? And I'm like, well, and so there is that. And as Kelly said, the same patient, when she had to go daily, was really feeling much worse about herself when she got to weekly dosing, or several times a week. That self stigma gets better, because there is that self talk of, oh, I'm not trustworthy, nobody trusts me, and a lot of patients give up with that when they hear that. They're like, why try if I'm just going to get treated poorly? There's really no benefit. So although addiction has a lot to do with negative consequences, I think it's the negative consequences of stigma that push people back towards it, and the positive consequences of recovery is actually, I think, more powerful than the negatives, because these people have a lot of negative consequences and they don't quit. So we need to try something a little different, because it just doesn't, negative's not enough. Obviously, I think you've been in jail, been overdosed, been hospitalized, been treated poorly, and you're still not quitting. It's pretty powerful addiction.
Yeah, that's the split dosing. That's really, in the urine drug screen, that's really interesting. Thanks, David. Any other examples from your own experiences?
I talk a lot, so I can give you some examples. Okay. So, I had one patient who was hospitalized for something completely different, was on buprenorphine inpatient just because they've been on buprenorphine a long time. And they were wanting to search their teenage daughter coming to visit, bringing food, because they're afraid that they're going to be bringing things in. Now, most hospitals have policies where they say we are allowed to search people, but it usually should be with cause, not based on stigma. So if somebody's stumbling in, well, that's maybe a reason. If somebody's behaving and you suspect that they're using, I think we've all had those situations where patients are bringing drugs into the hospital and misusing that. But this was presumptive, and patients just leave the hospital. They just get angry, and how would you like to be treated that way? I'm surprised, and so that's one of the Another one, unfortunately, is often our pharmacy systems, not necessarily always the pharmacist, but making a point of calling out a patient's medication in public when they're waiting for their Suboxone and not calling out others. Literally holding the medicine so that the patient has to reach for it. I mean, these are like really mean things, extremes that I have had people do. Things like that, the way they talk to patients about it. So yeah, so there's a lot of that going on. Family members, oftentimes partners, have a real difficult time with it. How can you do this to your baby? You need to stop anything. And there's, yeah, so I do see a lot of that.
And I try and invite, if people want to have their family members come in for any conversations around medication. SAMHSA has a really nice kind of medication for opioid use disorder pamphlet. Well, it's more than a pamphlet. It's a whole kind of reading for friends and family members. And that can be helpful if people will want to read something about it. But oftentimes validating is what we can do when they're experiencing that stigma, and also then working behind the scenes with our colleagues, to whether they be pharmacy colleagues, if that's possible, or other colleagues to help them understand that what's doing that is simply driving people away from the solution and the treatment that may be helpful.
I know we're constantly trying to do education, and I could give you a million examples too, but when you're talking about this, one that comes to my mind that really frustrated me was, just like you're saying, validating and continuing to have conversations. I just, I got called for a consult at the hospital for a domestic violence situation of a woman that just delivered. And now in this process, they moved the woman to a different room because they followed their protocol. They moved the woman to a different room, changed her room number, as the father went out to get something to eat. And she's trying to explain to them that there's not domestic violence. And they're like, this is our protocol. We have to do this. So when I talked to the social worker, I went and talked to the mother, and the mother was on MAT, and the baby was doing well. The baby wasn't even withdrawing. Like there was everything was going smoothly, except for this argument. And this argument took place because they weren't giving the mom her medication, and she was and he was getting frustrated because he was fearful that she would relapse. So they got into a verbal argument in their room. And when he left to go cool down and get her something to eat, they moved her room and everything. And she kept saying, like, this is not, we were just arguing. She didn't really want to share what they were arguing. But then when I talked to the provider about it, they're like, well, we saw that she has substance use disorder and heard the fighting, so we moved. And I was like, whoa, like, we can't combine everything. Like, let's look at this. And just having a conversation, nobody was really listening to her, having the conversation with her. And I was just like, wow, like how invalid, like she struggled to talk to me when I went over because nobody was listening to her. So why would she want to say that again? So it's just so invalidating, and it's hard. Yeah.
Yeah, that's a great example. And Amanda, I'm so happy you then were able to kind of circle around to the providers who may have, been trying to help in a way that was not helpful.
No. Yeah.
Something that comes up a lot on our unit, and Laura and I have a mutual person we care for that we hear about this a lot, is when you're admitted long-term on our unit, you are not allowed to leave the hospital. And which makes, you could argue it would make sense from a liability standpoint, but when you consider people who are there long-term, for example, someone who's pregnant with severe preeclampsia admitted for several weeks, or someone with preterm premature rupture of membranes who's admitted for several weeks. It's not good for your mental well-being to be locked in a building, unable to leave the unit you're on for weeks on end. And so we kind of struggle with developing a policy where right now the loose policy is that people can go outside if they're accompanied, as long as they don't have a history of substance use disorder. If you have a history of substance use disorder, you're not allowed to leave, which is horribly stigmatizing, right? Because you're like, I would argue if someone's admitted for glucose control for diabetes, no one's policing if they can go outside and what they're eating, and if they go to the cafeteria and order things not on a diabetic diet, but we don't translate that the same with someone that has a history of substance use disorder. So even small things like policy formation is huge.
Yeah, and for this patient, if she left, I was trying to like go see her at least once a day, and Kelly was going to see her once a day, and I would take her outside and we would go for a walk. But I'm not there on Saturday and Sunday, and so they would if she left without unaccompanied, they would discharge her, and she would have to be readmitted. I mean, it was really felt a little crazy.
Yeah. And we're talking like they would discharge her to the degree that you have to have your IV taken out. She would have to pack all of her belongings up, go outside. And then when she came back in, it was an entirely new admission with a new urine drug screen with a new IV placement on someone with a history of injection drug use. So they have a lot of scar tissue and a difficulty with getting venous access.
Yeah, so working with institutions can be a challenge to help them.
The irony of that is the work for the nurses, they just tripled their work. They have to readmit them. They have to spend 2 hours trying to find her IV, and they know they're going to readmit her. They're not going to not admit her. We can't not admit her. It's the same thing. Many of our patients that are, unfortunately being treated for complex infections with not giving them, portal access, because they may abuse it. They actually generally don't abuse that. They have no trouble accessing their veins. We have trouble, but they have no trouble accessing their veins. So that's another level of stigma that the healthcare system, you really do get a different. And then even if we carry that over to other patients, I had one patient who was on chronic pain medication for childhood osteosarcoma, and was told that she needed to switch to Suboxone, which was no need to do that. She could have continued on her pain medication. But once she's on the Suboxone, who does that? Well, substance use programs, me. Nobody would do it for her. So she came into our program. We said, well, she actually was very interesting. She said, no, I'll go through the normal program. And she learned so much about substance use and the stigma, because all of a sudden she was being faced with everything everybody else was. Although she didn't carry a diagnosis of substance use disorder, she had a dependence. And she chose to continue in the group because of the support she got from everybody else. It was very interesting that they were very supportive of her, and she was everybody else. And, it was never, oh, I'm not like the rest of you. There was always topics that, she tackled. But yeah, she experienced all that in the pharmacy, the hospital, everything else somebody else would have gone through.
Yeah, so I thank you for sharing that, because I wanted to end on a positive note, which is actually when we treat pregnant and postpartum women in groups with their pregnant and postpartum peers, it helps reduce that stigma and that guilt and shame tremendously. So this same patient that Kelly and I worked with and used methamphetamine throughout her pregnancy and had her child removed. She did not use opioids. She was stable on medication for opioid use disorder. Every time there is a new patient who comes in to our group filled with guilt and shame because she has not been able to quit using, this individual is the first one to step up and share her own story and say, don't beat yourself up. There will be consequences, like CPS may take your child, and you can you can fight to get them back the way that I'm doing. So so that group support and lived experience and shared understanding is huge in the treatment setting as well.
Any final comments or questions? This has been great.
Kind of just a little motivational side plug for everybody is like, even in just like minor, I think that like minor contacts where you don't feel like you're making that big of an impact, but maybe you made a safe, supportive environment and you used like language that was supportive of people and were not judgmental, that spreads a lot. I don't think I realized how important that is until like literally just a couple months ago. Someone just like happened on my schedule for a prenatal visit and disclosed that they were using and that they were like had gotten into treatment and said like, I'm so glad I got to come see you. I heard you're really nice to people in recovery. And like never had I like really felt like I was like, oh, like she was like, I heard like the word is that you're nice and that you're not judgmental. So like even those like small like ripples where you're just making people feel safe like is huge. Because I was like, man, I never like had really felt like that did a lot for like, okay, I'm like doing the right stuff. Like clearly there's always room for more growth and improvement, but having someone be like, I heard that you were safe and respectful, it can be huge. So just keep implementing those things and it makes big impact for people.
I think having a team too, like I mean, I'm gonna just toot our horn for a minute, but I think we're a great team. Like Laura, Kelly, and I all work together on the same team. And I think as our women transition between groups and see us all together and working together and advocating for them together, they know when they're doing the right thing that will advocate for them. And they know when they're not doing the right thing that they can come there and talk about it. And I think that really helps support that too. So just saying, I love the team.
That's a good one to close out the session on. That was great. Thanks, Kelly. We appreciate everybody coming on today. We're going to be meeting back up on September 11th. So be on the lookout for communications on that. And we will also send an updated schedule for the rest of the year out here shortly. So be on the lookout for that so you can kind of see what's coming up for the rest of the year and the dates and everything. We'll try to attach that to the recap email, but if it's not quite ready, we'll get it out shortly after, but be on the lookout for that as well.
All right. Thanks, everyone. Good to see you.
Yep. Take care, everybody.